Alright, hi guys. This week we're going to pick up where we left off last time. So we're going to be picking up with chapter 68 of musculoskeletal problems and Lewis Medical Surgical, I think 12th edition. So this is a relatively short chapter, so I'm going to finish these 3 slides and then we're probably going to do some practice questions because the next chapter is Grad and it's relatively long. So we're going to pick off with intervertebral disc complications. So basically the purpose of these intervertebral discs are responsible for separating our vertebrae, right? And it provides shock absorption. So as people get older and the discs degenerate, they lose elasticity, flexibility, and shock absorption because the discs tend to thin out. So there's several classifications such as cervical disc disease, and it's usually classified with upper body pain. You have some of these decreased reflexes and decreased grip strength here. In intervertebrate disc disease, it's usually lower body pain that's radiating, and you also get the decreasing reflexes, the muscle weakness, and you will have a positive straight leg test and also paresthesia. Now, probably the most important and high yield one is multiple nerve root, which is cauda equina compression, and this is a medical emergency. We can go into more detail once we hit critical care and talk about like spinal shock and all these other spinal problems that are more severe. But basically you need to know for now for a med surg level is that it's increased radiating pain, there's going to be muscle weakness, and they don't have much control of their bowel and bladder. So some nursing interventions you want to be aware of for these spinal injuries and diseases is that you want to use pain. It's really painful, so NSAIDs and opioids are obviously great choices. Corticosteroids, obviously to reduce inflammation, but also be wary if they have an infection going on at the same time. Antidepressants, because it can be a huge change in their quality of life because of all these pains and decrease in reflexes and loss of muscle strength. It can be a huge change from what they were used to. You can also have anti-seizure medications, muscle relaxers, and promoting back exercises, so you can consult PT. Now, all that stuff being said, I do personally feel it was relatively low yield on the NCLEX and like exit exams like HESI and all that stuff. Personally, I do feel this topic though coming up is a little bit more high yield, if anything, or like I would say medium yield. It's not like the craziest high yield topic ever, but CSF, cerebrospinal fluid leakage. There's 2 ways to check it, right? So first off is the halo sign, which we have this picture here. If you take this blood and then it should like mix with the CSF, it should kind of disperse and form this little halo ring. So you want to know any description with an answer of saying a halo is really indicative that there's CSF in the fluid. Also, you can test the drainage, right? So if they have like, let's say, surgery and let's say it's in the nasal area and it's like dripping and it's like white, you're not sure if it's mucus or not, you can go test it with a glucose strip because it tends to be positive in glucose. CSF tends to have about roughly 60 to 70% of the blood glucose level compared to mucus, which is relatively rare to have glucose in it. After surgery, you want to do your neuro checks. You want to assess the CSM, which we went over I think 2 weeks ago, which is like the circulation, sensation, movement, mobility, and that kind of stuff. With whatever hospital policy you guys have within the first 2 days. And you obviously want to compare with preoperative and postoperative findings. So like this is like basically a huge part of nursing where we're kind of just looking and comparing at the person's before and after. Are they back to baseline? Is it not normal? So this is why when you go into like surgery or anything, the nurse will check your feet pulses, right? Your pedal pulses. If it's 2+ going in, they should be 2+ coming out, right? Because if it's not, something probably went wrong and we need to report that to the doctor and say, hey, something's not right. You want to monitor the GI and GU function because there can be nerve damage if there's a loss of the bowel and bladder control. This is also hinting more at the cauda equina stuff. And more importantly, you want to stabilize the back with like a collar brace to protect the neck as well. And it's important to log roll the patients. I remember studying for this exam, and a lot of the things they tested on weren't so much like the details of what was like cervical, spinal disease, and intervertebrate disc disease. It wasn't really much of that. It was kind of just like common sense. Like, are you gonna pick up somebody, who got into a traumatic car accident and let their neck flop about? No, you want to like use the collar brace. You want to log roll them, which basically means rolling their entire body as one, so you don't try to dislocate any of the spines and vertebrae in there. So now, osteomyelitis is one of the two diseases that we talk about for musculoskeletal problems in this chapter. And the first one, obviously, like we said, osteomyelitis. Every time you see the ending itis, I want you guys to think of infection, and osteo means bone. So it's infection of the bone or bone marrow. And to be labeled as chronic, it needs to last greater than a month, or an infection that was not treated with the initial treatment. Like I said, I won't really worry too much about the definition too much, but it's kind of good to have a general feel that chronic things are usually a month or longer. So some signs and symptoms are fever, chills, malaise, right? That's pretty common and shared amongst all infections. Night sweats, now you're narrowing it down, right? Because I think TB is also night sweats, but other than that, there's very few. But there's also restlessness, nausea, vomiting, and at late stages there may be drainage from the bone marrow. The way you diagnose this is obviously through imaging, right, or a biopsy. So surgeons can take out the bone biopsy, or you will need to do X-ray, MRI, CT. And the reasons why we monitor white blood count, which is WBC, and the blood and wound cultures is for white blood cells will be increased if there's an infection, and blood and wound cultures can help us identify the strain of bacteria, right? ESR and C-reactive protein, these are things that increase when there's an acute inflammation going on. So these values in the lab chart will also be increased. Now, the book says treatment requires 4 to 6 weeks of IV antibiotics, but obviously go with whatever your hospital policy is in the future. But just like, for testing purposes, this is what we were tested on. But like I said, they didn't really test you too much on the duration of the treatment, So some surgical care is like muscle, skin, bone grafts. You want to remove any hardware, like implants, etc. And you want to debride the bone and tissue. That's probably the most common one that I would say happens, is they debride the bone and tissue from the infection. And there's also options of drainage where they can try to drain the infection, the pus, and all that stuff that's in the bone out. And as a last resort, amputation. And that's obviously why we kind of talk about like antidepressants being one of the medications for these, musculoskeletal issues, because if it comes to amputation, it can be a huge change in their lifestyle and their perceived self-image. Now, the second disease is osteoporosis, and this is very common, very mainstream topic. So it's low bone mass and deterioration of bone tissue. Risk factors are Asian and Caucasian women that are a bit on the elderly side, and there's a recommendation at 65 years old you should repeat Q15 years for the bone density scans. But this disease, although there's a genetic component and a gender component, there are still things that you can do to try to prevent it, such as regular exercise and increase our calcium intake. Here you have the values of like how much you should be consuming each day. I wouldn't really worry about it too much, because this is like low yield detail stuff that I feel like is not very rewarding to memorize. I would just understand that you want to increase your calcium intake, so any of these things right here help promote strong bones. And that's like something that's been drilled into our heads if we were born in the United States, right? There's this whole campaign of like, get strong, or like got milk and all that stuff, right? So along with calcium, you want to increase your fluoride and vitamin D intake, and the vitamin D and calcium often go hand in hand because of the increased absorption and how it's supplemented into like things like milk. Clinical manifestations of osteoporosis is that you can have fractures and back pain. They get shorter, and then they also have kyphosis, which is the hunchback kind of appearance that older adults tend to have. And there's some common sites such as the wrist, hips, and spine, which will most likely get affected by this degeneration of bone tissue. How you diagnose it is ultrasound and dual energy X-ray, which is obviously, imaging stuff, right? Because you can't just, you need to look at it. Medication therapy, this is a little bit of pathoform, so I'll go into it a little bit here, but it's kind of important. So biphosphonates, so basically they're the number one treatment in inhibiting bone reabsorption, right? Because phosphorus and calcium have a negative relationship. I believe we covered that in my first video. So some things you need to remember about biphosphonates is take with a full glass of water, take 30 minutes before food, and sit upright, okay? And also what is not mentioned on the slide is biphosphonates can cause this osteonecrosis of the jaw. So it can cause jaw problems, so that's something that you need to think about when you are giving a patient biphosphonates. So if they're receiving or reporting any pain in the jaw, make sure you let the doctor know. Calcitonin, or as we refer to it, calcibonin, because it inhibits bone reabsorption. It is given through an inhaler, so you want to alternate nostrils, and you must take a calcium supplement. And here's some other medications like Avista. This one's like an estrogen receptor modulator, which is partially the reason why women tend to get osteoporosis more, because of how estrogen plays a role in the bone deterioration. But honestly, this one was actually pretty low yield. Forteo, it impacts the PTH, the parathyroid hormone, and it stimulates newborn formation. So honestly, if I can only remember a couple of these, I would recommend these two and Forteo. And just remember, biphosphonates has the jaw necrosis thing going on. So this is where I'm going to leave off for today, and then if you guys want to stick around, I'm going to do some practice questions. And as you can see, it's really quite long. So let me jump to the section here. Okay, so this is going to kind of be like a reference of, or everything we talked about from the previous few weeks. So we're going to start with the sliding scale question. I'll give you guys a few minutes to pause and answer these questions on a piece of scrap paper. Okay, I'm going to show the answer now. If you guys haven't finished yet, just remember to pause and pick right back up when you're done. You guys should know how to answer it based on the sliding scale, and it's pretty simple. It's just reading the scale. If not, you guys can leave a comment and I can explain how to read it later. So the next question is, a patient with type 2 diabetes is scheduled for a follow-up visit in the clinic several months from now. Which test will the nurse schedule to evaluate the effectiveness of treatment for the patient? So I'll give you 1, 2, 3 seconds, and if you still need more time, pause and come back. But the answer is D, glycosated hemoglobin level. So if you guys were having trouble with this question, maybe it's because you guys didn't recognize the vocabulary term. This is just basically the same thing as A1C, and it's the best thing to determine a patient's blood sugar control over a 3-month period. This rationale basically says fasting blood level indicates only the glucose level at one time. The urine glucose test is not an accurate reflection of overall blood glucose level and over a prolonged period of time especially. And oral glucose tolerance testing is done to diagnose diabetes, but it's not used for monitoring glucose control, okay? So this is really high yield. Like, you can definitely expect to get a question on this at least once in like your nursing school career. It's going to be so obvious. The next question is, a 38-year-old patient who has type 1 diabetes plans to swim laps daily at 1 p.m. The clinic nurse will plan to teach the patient to A, check glucose level before, during, and after swimming, B, delay eating the noon meal until after the swimming class, C, increase the morning dose of MPH insulin, D, time the morning insulin injection so that the peak occurs while swimming. And I'll give you 3, 2, 1, and the answer is A. So anytime that a patient is about to participate in a strenuous activity like exercise, you want to make sure that they are checking their blood sugar levels throughout and before and after the activity. And it's also advised for them to eat like a small snack as well before they start because exercise tends to decrease their blood sugar and you don't want them to crash. Increasing the morning MPH or timing the insulin to peak during the exercise may lead to hypoglycemia because, as we talked about earlier, when you're increasing the exercise, your blood sugar tends to drop. So you don't want to time that, that drop happening. So you kind of like be doubling down on that. Okay, so third question: which finding would the nurse expect when assessing a patient who has osteoarthritis of the knee? A. Presence of Herbender's nodules. I'm totally butchering that name. B. Discomfort with joint movement. C. Redness and swelling of the knee joint. D. Stiffness that increases with movement. I'll give you 3, 2, 1. And the answer is B. Discomfort with joint movement. So the initial symptoms of OA, osteoarthritis, includes pain with movement, right? Herbender's nodules, it occurs on the fingers. The question here says of the knee, so you can automatically rule out A. It's not a thing on the knees, it's on the fingers. Redness of the joint usually is indicative of like inflammation, and that's more in line with rheumatoid arthritis, RA. Stiffness in OA is worse right after the patient rests and decrease with joint movement, which is kind of the opposite with RA. So like people with RA need to like warm up to get those joints moving, and it feels worse after they take like a long sleep. I think I screwed that up, sorry. Stiffness in OA is just worse right after the patient rests and decrease with joint movement. I'll just go with that. I'll go break it down later if there's still any questions about RA versus OA, but I think we covered that a long time ago. So the nurse is assessing a patient with OA who uses naproxen, so this is an NSAID, okay, for pain management. Which assessment finding would the nurse recognize as likely to require a change in the medication? A. The patient gained 3 pounds. B. The patient has dark-colored stools. C. The patient's pain affects multiple joints. D. Patient uses capsaicin cream. And I'll give you 3, 2, 1. And it's obviously going to be dark-colored stools. I kind of hinted at, the answer because by telling you naproxen is an NSAID, and with NSAIDs there's obviously the risk of GI bleeding, right? And every time you have dark-colored stools, this is like key vocabulary, like that's always hinting at there's going to be blood, basically. So yeah, the rationale says that the dark colored stools may indicate that the patient has GI bleeding caused by the naproxen. The patient's ongoing pain and the weight gain will also be reported and may indicate a need for different treatment and or counseling about avoiding weight gain. But that's not like the main point of the question, right? The main point of the question is asking, which is most likely to require a change in medication, and although gaining 3 pounds and the pain affecting multiple joints, like it's not effective or there's just pain in various areas, the priority is going to be the dark colored stools. And using capsaicin cream is like often used alongside with oral medication, so it doesn't really need a change, right? The main change is that the change that needs to happen is that there's GI bleeding, which is dangerous. So the nurse would anticipate the need to teach a patient who has OA about which medication: prednisone, Humira, Zostrox, or sulfasalazine. Now this one's a little bit tricky, so I wouldn't really worry about too much about getting it. I didn't really like the question. I think this was one that a friend of mine wrote or pulled, but I didn't really agree with this one because I do feel it's kind of low yield. But anyways, the answer is going to be in 3, 2, 1. Capsaicin cream. So like we kind of talked about earlier, OA gets treated with capsaicin cream. Rheumatoid arthritis is more of like the steroids and Humira, which I think is a TNF, a tumor necrosis factor drug, and sulfasalazine. Like honestly, I totally forgot this was a thing. But this is why I didn't really like this question, because this is more of like you know it or you don't, and you kind of just have to understand that like these 3 are for RA and this one's mainly for OA, which I didn't think is very fair, because I feel like a lot of the questions on NCLEX and HESI can be deduced and logicked out. There are very few questions that you just like have to know. A patient being seen in the clinic has rheumatoid nodules on the elbows. Which action will the nurse take? A. Draw blood for rheumatoid factor analysis. B. Teach the patient about injections for the nodules. C. Assess the nodules for skin breakdown or infection. D. Discuss the need for surgical removal of the nodules. Oh, sorry, I didn't count down. But it's C. And the reason why is because like you can answer this question with the nursing process, right? Like you always want to assess, diagnose, or like the nursing diagnosis plan, right? All that stuff. And assess is like the first line, right? Because this is a very bare bones question, so you don't know much. So you want to see if there's any, you need like a direction to go in. So our assessment will kind of create that direction for us. And you don't really like remove the nodule surgically because they do tend to grow back, and you don't normally inject them with like anything. So which action would the nurse include in the plan of care for a patient with a new diagnosis of RA? A. Instruct the patient to purchase a soft mattress. B. Teach the patient to use cool water when bathing. C. Encourage the patient to take a nap in the afternoon. D. Suggest exercises with light weights several times daily. And the answer is in 3, 2, 1, and it's C. Encourage the patient to take a nap in the afternoon. So the reason for this is because RA patients tend to get really tired and fatigue really easily. So that's why you want to encourage naps. You want to avoid stressing the joints, and cool water is not correct. You want to use warm water. So you often think about warm showers with RA. And you also want a stiff mat, like a firm mattress. If they sink too far in, it can cause stress on the joints. When a disease is stabilized, a PT will usually just develop a program for them that will then focus on building up the flexibility and strength of the affected joints, but not when it's a current like exacerbation of the disease. We want to just make sure they're okay first before you worry about getting them back to like their strength or having muscles. Okay, so this is where we will leave off for today. We'll pick up on Grad next time. But yeah, sorry for the lack of videos. Last week I had a pretty stressful, long, like 9-day stretch of work, but some updates is that I'm going to be going independent in my new grad program, so I will be having my own schedule and I will no longer have a preceptor following me, so it's just a pretty stressful time at work for me. And a lot of things going on in my life right now. I did recently just get the COVID and flu vaccine at work yesterday, and I woke up with like a pounding headache. I regret taking both vaccines at the same time. I should have spread them out. But yeah, hopefully these videos help you enjoy. Happy studying!